We've been called to a 24-year-old female who's had a spontaneous onset of a nosebleed while watching TV. There has been around a 200 mils of blood lost over the last 45 minutes. Now it's not spurting out, it's just drooling. Now this patient has no allergies, is not on any regular medications, has a past medical history of recurrent epistaxis over the last couple years, and last food or drink was lunchtime, and the events up to the nosebleed was that the patient was gardening prior, and it was quite a warm day, so they came inside and the nosebleed started. Now I have instructed the patient to sit forward and pinching the fleshy part of their nose, as well as applying a cold press to the back of their neck and to aid vasoconstriction of the vessels. Now this has been done for 15 minutes and we will reassess after those 15 minutes. 15 minutes has passed now, and so we've reassessed the bleeding and the bleeding has continued. Now I've advised the patient that we will be administering some intranasal adrenaline as it aids in the vasoconstriction and will hopefully help the bleeding stop. So this will be drawing up our iron adrenaline. We have our adrenaline, which has been drug checked by my offsider. We've got the saline solution that's also been drug checked. Our drawing up needles, a 3 ml syringe and a 10 ml syringe, and the mucosal atomizing device. I'll start by drawing up 9 ml of saline into the 10 ml syringe. Cool, and then I will be drawing up 1 mg, the 1 ml of the adrenaline, and I also have a sharps container available. So this now is a 1 in 10,000 solution of adrenaline and saline, so I will now be transferring 2 ml of this solution into my 3 ml syringe. Now I have 2 ml of 0.2 mg and 2 ml of adrenaline that I can now put into the patient's nose. So we have Gemma here who's been holding her nose for the last 15 minutes. So what we're going to do is reassess her nose bleed to see if it's still bleeding, and if it is, we will apply the iron adrenaline. Now this will hopefully stop the bleeding with all the vasoconstriction of the vessels, and so what we'll do, if we can, we'll have a look at your nose. Okay, so it's still bleeding. If you could please put that back on. So it's still bleeding, so we'll apply the iron adrenaline. So what we'll do is, what I'll get you to do is, if you can just blow your nose, so blow off all the clots, and then that way, if I can get you to lean your head back, I'm going to put this in your nose, and then when you take a nice big sniff, when I tell you to take a nice big sniff, I'll put this in. Okay, and 1, 2, 3, sniff. There we go. So yeah, if we can get you to hold your nose for another 15 minutes again, and then we'll reassess to see if that bleeding has stopped. So another 15 minutes has passed again. If I can see your nose. Awesome. So it looks like the bleeding has stopped. So now I'm happy to leave you at home. However, if your bleeding does start again, do go see your GP, and I would recommend that you go see your GP in the next couple of hours, just because I have given you that adrenaline. Is that okay?
Yeah.
Cool. Now, okay, so just for the next couple of days, I would advise to avoid hot showers, picking your nose, blowing your nose, or trying to sneeze, as it might blow the clots and your bleeding might start again. Now, do you have any pain there at the moment? No. Cool. So what I will do is I'll finish off my paperwork, and I'll give you a little piece of paper as well to just let you know to go see your GP and everything, and some other pieces of advice. Now, if this patient was taking any anticoagulants or anything like that, or the bleeding was moderate or severe, I would advise a transport to ED to get assessed, as well as I will be going through a non-transport pause checklist with my offsider just to make sure that we've got everything that we need to leave this patient at home. So going through the non-transport pause with my offsider, so this single patient has been given a recommendation by ambulance personnel that the transport to a medical facility is not required this time. So this checklist will be completed prior to leaving the scene. So the patient has been fully assessed, including a set of vitals and appropriate investigation. So there is no abnormal vital signs, which is also the next checklist point. There is no serious illness or injury and has been reasonably excluded. We did a secondary survey and that came up with nothing else as it was isolated nosebleed. The patient has been seen mobile and the patient and caregivers had been given a clear explanation to seek further help, which is going seeing the GP, calling us back if the bleed is severe enough, as well as a PRF has been completed and a copy has been left with the patient. We've been called to a 22-year-old female who is complaining predominantly of a headache behind her right eye. So doing a sample history on Gemma, we've come to the conclusion that she has no allergies, she's not on any regular medications, she has a past medical history of recurrent migraines. However, she doesn't have a history of any intracranial bleeding or a family history of any cerebral vascular abnormalities. Her last oral intake was 3 hours ago, and Gemma started complaining of a headache after she experienced some blurred spotty vision, and the headache came on gradually. So doing an OPQRST assessment as well, a pain assessment, the onset of the headache was after the blurred spotty vision. There's nothing that makes the headache better or worse. There is a dull throbbing ache behind the right eye that is explained as a headache. It's non-radiating, her pain score is 5 out of 10, and the headache came on roughly an hour ago. Now, Gemma has not experienced any coryzal symptoms. There's no trauma, so serious illness or injury can be ruled out, and the headache did not come on during sexual activity. No abnormal vital signs, and Gemma has not suffered from an altered level of consciousness, as well as not experiencing any nausea or vomiting. And Gemma is not suffering from any photophobia, or however, is experiencing that blurred spotty vision, which is a normal onset for her migraine. Now, if I was seriously worried of Gemma's headache, I can call the clinical desk for advice, which due to the blurred spotty vision, as it can mask photophobia and can indicate an increased ICP or intracranial pressure. So now I will assess Gemma herself and see if I can rule out anything further that it can be more serious. So I'm just going to do assessment now with Gemma. Is that okay? Yeah. So it's the FAST test. So can I please get you to give me a nice toothy smile? Awesome work. Now can I get you to please bring your arms up but palms up, and then close your eyes and keep them there for 10 seconds. Awesome work, you can put them down now. And now can you please say baby hippopotamus for me?
Baby hippopotamus.
Oh, awesome. So I can now say that Gemma has passed the FAST test, and I can rule out stroke as she has passed all those assessments just there, and her onset of her headache was just an hour ago. So now I'll be doing a cranial nerve assessment. Is that okay? Cool. So what I'm going to do is I'm just going to put my hand on both sides of your ears and just going to, does it sound the same to you?
Yes.
Cool. And your nose, do you have any funny smells or anything like that?
No.
Does it all smell as it should?
Everything's normal.
Perfect. And same with taste, is everything tasting the same?
Yeah.
Is everything in your mouth feel as it should?
Yeah.
Cool. So also, can I get you to track my finger with your eyes but without moving your head? Cool. So there's nice, equal and smooth tracking of that. I'm also going to check your depth. So Does this look all the same when I'm bringing my fingers forward and back?
Yeah.
Awesome. Now, if I can I get you to scrunch up your face for me? Awesome. And then bring your eyebrows together. Perfect. Now, is it okay if I just have a feel of your sinuses? Awesome. So I'm just going to go on the bridge of your nose and underneath. Does that all feel the same? Perfect. So, Gemma's cranial nerves are all showing really good results. So I would like to do another assessment just on your neck, if that's okay.
Yeah.
Cool. So if I can, I'll have a feel down your C-spine, if that's all right. Do you have any pain there at the moment? Okay, cool. So if I'm feeling down your C-spine, does it hurt at all when I'm doing that? Okay, awesome. And can I please get you to rotate your head side to side? Is there any pain when you do that?
No.
Cool. And can I get you to touch your chin to your chest? Is there any pain when you do that?
No.
Okay, awesome. So from this and the assessments that I've made today, I believe I can leave you at home. Is that all right?
Yeah.
Cool. Cool. So I can actually administer you some pain relief prior to me leaving for your pain. Is it? Do you want that?
Yes, please.
Cool. So I've got some paracetamol and some ibuprofen here. Are you allergic to those at all?
No.
No. Okay. And you haven't had anything for the pain today at all?
No.
No. Okay. So I'm going to give her the paracetamol and ibuprofen since she has not had anything within the last 4 hours. And are you above or below 80 kg?
Below.
Awesome. So I'm going to give her 1 gram paracetamol and 400 milligrams ibuprofen, and also she's not presenting with any paracetamol poisoning, so that's the contraindications are now ruled out. So here's the paracetamol and the ibuprofen. Now these have also been drug checked by my offsider. So while you're taking those, I will just go through the red flag checklist. So please correct me if I'm wrong with anything. So headache or neck pain following manipulation has been ruled out as there's no pain. Neck pain or neck stiffness, no. There's no sudden onset of severe headache, as it was a gradual onset. There is no temperature greater than 37.5 degrees. There's no persistent vomiting. There's no focal neurological signs. There's no altered level of consciousness or a history of altered levels of consciousness. And there is no worsening headache following the recent trauma of the head. We haven't got, Gemma's not taking any anticoagulants, and there's no signs of temporal arteritis or hypertension during pregnancy. There's no previous history of any intracranial bleeding, and there's no family history of any cerebral vascular abnormalities. And the onset of the headache was not during sexual activity. There's no symptoms involved with sinusitis, and the migraines, the onset of this headache is usual to the normal migraine onset. So Gemma will be left at home with the information from our paperwork, the ACS form containing our advice and recommendations, as well as the non-transport information sheet for a headache. Now the advice for Gemma is for when to call us back is if the headache does become more severe and cannot be controlled with pain relief, as well if she is unable to mobilise due to the dizziness or severe vomiting. However, we will organise an appointment with her GP today within the next couple of hours to get this headache further assessed.